Good morning, everyone. So today we'll discuss percutaneous stenoscopic lumbar decompression surgery, technical tips and tricks. Introduction. Degenerative changes in the spine structures including the disc, ligamentum flavum and the facets leads to the spinal stenosis. Spinal stenosis is a common indication for spinal surgery in patients more than 65 years old, which may contribute to central stenosis, lateral recess stenosis and the foraminal stenosis. In young, due to increased sedentary lifestyle and poor dietary habits, these spinal pathologies can be seen earlier in the 40s. Other pathologies like facial cyst or synovial cyst or spondylolisthesis is also found. What are the anatomical considerations for the percutaneous stenoscopic lumbar decompression surgery? Now we have to understand ligamentum flavum is consist of two layers. The superficial layer, which is a loose fibrous tissue layer, and it is obliquely arranged fibers. The deep layer is attached to the ventral surface of the lamina, and it is quadrangular sheets of the fibers and foraminal part which extends deep into the foramen and merges with the facet capsule. So this thing we have to understand, and we have to drill the upper lamina till the point we see the attachment of the deeper layer, and then we should start the flavectomy. We will see this thing in our operative video. So how to do the pre-operative planning? First is plane radiograph, which is really very important. You have to do the AP view, lateral flexion and lateral extension view to see for any instability, and the AP view you have to look for the interlaminar window, and you have to correlate your MRI, target MRI level with the X-ray MRI level as you are going to see the CM or the X-ray image during the surgery. Now next investigation is the MRI, which is the investigation of choice for the spinal pathologies to look for, like disc or the stenosis. And also you have to plan your docking point and the extent of the resection in the MRI only. So sublaminar approach or subarticular extent of the ligamentum flavum you have to look for into the MRI. Also in the cross-sectional area you have to in the axial images you have to look for the cross-sectional area of the dural set, in the midline, at the lateral recess and at the foramen, so that you can plan your decompression and you can compare post-operatively the adequacy of the decompression. CT is required to see for the shape and orientation of the facets, and any iatrogenic instability present in the scan. Sometimes ligamentum flavum is ossified. You can also appreciate this thing in the CT scan. Anesthesia. When you are starting your surgery, endoscopic surgical career, you can take the patient in general anesthesia. I usually operate all my cases in spinal anesthesia, SOS in sedation. So position is typically in a prone position, and all the pressure points should be secured. Abdomen should be free floating, so that there should not be increase in the abdominal pressure, and all the IE and the pressure points should be well padded. So a waterproof surgical drape should be applied as this surgery is done under continuous line irrigation. In the AP view, you should draw a midline, and just you have to identify the target level, and you have to give the just the paraspinal or para midline, just lateral to the midline, a skin incision. So typically the OR setup remains like this. Surgeon stands on the side of the pathology. If the pathology on the left side, surgeon stands on the left side. If the pathology is on the right side, the surgeon stands on the right side. In front of the surgeon lies the X-ray technician or CM technician and the image processor along with the fluid irrigation system and the pump. On the side of the surgeon, usually the scrub nurse with the instrument trolley is there. Cranially, the anesthetist stays, and caudally, all your RF machine and motorized instrument console remains on caudally. So this is a typical OR setup that you can appreciate. What are the anatomical landmarks of the docking? First, you see this red line, and then the circle and the blue circle. So red circle is the most common utilized docking point. This point is red point is upper spinal laminar junction or cranial spinal laminar junction. It is mainly used when you are dealing with the stenosis work. Next is the green circle. Whenever there is only disc, fresh disc, like at L5S1, you don't want to remove, you don't need to do the laminotomy. You just interlaminar window is big. You just want to remove the disc. Then you just land on the green circle, remove the lateral do the lateral flavectomy, and just directly approach the disc and remove the disc, do the discectomy. So no need for the cranial decompression. If the your disc is caudally migrated, then you should land on the lower spinal laminar junction, that is a blue circle, and can drill part of the lower lamina or laminotomy, and then you can approach, you can do the lateral flavectomy and can approach to the disc. So these are the three anatomical landmarks where you should first dock your obturator or the dilator and put your working sleeve inside. So surgical steps remains. First is the level marking, just on the side of the pathology, just paraspinal, lateral to the midline. You should dock and confirm the level. Put make a skin incision and go inside. Typically, this incision remains around 9 millimeter, as your scope is 8.4 millimeter and the working sleeve is 9 millimeter. So it typically remains 9 millimeter or 9.1 millimeter maybe. So after dilation, put your obturator inside, put the working sleeve inside, remove the dilator and put your scope inside. Once you put your scope, then you will be having such kind of. So this is a case which I will be presenting as a case example. You can see there is L4, L5 stenosis, L3, L4 stenosis and L5, S1 stenosis. For the demonstration purpose, I will show only L4, L5 stenosis. So you can see this is grade 3 stenosis lateral recess. Now first you, as soon as you enter into the space, so you will see the soft tissue, clear the soft tissue, start with your drill, and in the pendular fashion slowly and slowly remove the upper lamina, and keeping the ventral of the lamina intact. Then you can use your punch and slowly you can take the bites cranially. It is really very important to preserve the facets, as we are doing endoscopically, and the idea is to preserve the facet. So then you start your flavectomy. You have to make sure whatever you are removing, you should see it first. If you are looking at the fat, then you are 100% sure that dura is down. So you have to be 100% sure. If required, you can do the ipsilateral or the contralateral facectomy. It should be limited, as as your instrument can go down, reach inside, and you can do the decompression well. So after the ipsilateral facet drilling, you should do the contralateral facet drilling, as this is a very narrow canal, and using your caissons number 2 and the number 3, go slowly, always see the dura, and do the flavectomy slowly. You can see the lateral recess is very tight. You have to be careful. Use the water irrigation medium, as it always separates the ligamentum flavum from the dura. Once you remove the ligamentum flavum, you can just retract the traversing nerve root using the RF probe, flexible probe, and you can do the bit of the annuloplasty, cut the annulus, do the discectomy. Yes, this is really very important. All the instruments should open once you are inside the disc, and then you remove the disc. And whatever the free fragments you should remove. If there are no free fragments, no need to do the radical discectomy. Do the annuloplasty and come out. The same thing should be done on the contralateral side. Using the nerve root retractor sleeve, you can retract the contralateral traversing nerve root. Then neovascularization at the annulus, you can do the radiofrequency ablation, put your annular cutter inside, and start doing the discectomy. Once discectomy is done, do the annuloplasty, free the condylated nerve root and do the bilateral traversing nerve root decompression. So these are the ways that these are the steps with which we do our surgery. This is really very important to achieve the hemostasis, and in this way we can appreciate we have good dural pulsations and complete ligament of phlegm has been removed. Nerve roots are absolutely decompressed on both the sides. We can appreciate the free traversing nerve root going inside, going down, and after that we can place our drain and single suture we can close the wound. So these are the typical this is a typical decompression, lumbar decompression endoscopically. What is the adequate decompression? First is free lateral recess, free floating dural sac, and free traversing nerve root in the epidural space. So typically such kind of MRI will be appreciating before surgery and after surgery with a good decompression post surgery. So what are the advantages of endoscopic spine surgery? Endoscopy provides you the benefit of the magnification, and also endoscope remains near the target. With both the things in unison gives you fantastic view and also allows you to look around the corner. As a lens is at an angle, so it always give you better visualization. You can look around the corner, and also there is very less chance of the facet joint complex, less injury to the facet joint complex. You are doing very calculated facetotomy, whatever is required, only that part you are doing, and as your scope can go inside, you are doing limited facetotomy. Post surgery pain is almost nil as there is minimal incision and you are not cutting any muscle, you are just dilating the muscle. There is reduced collateral damage, minimal muscular trauma, and more so over there is no dirty scar later on, less post operative pain, and recovery is really very fast. Thank you. I do hope you will opt this technique as this is much better and technically advanced surgery for the patients. Thank you very much.